This is a white blood cells, lymph nodes, spleen, and thymus. Disorders of white blood cells can be classified into two broad categories: proliferative disorders, in which there is an expansion of leukocytes. Number two is leukopenias, which are defined as deficiency of leukocytes. Proliferation of white cells can be reactive or neoplastic. Reactive proliferations in the settings of infections or inflammatory processes, when large numbers of leukocytes are needed for an effective host response, are fairly common. Neoplastic disorders, though less frequent, are much important clinically. The numbers: leukopenia. The numbers of circulating white cells may be decreased in a variety of disorders. An abnormally low white cell count usually results from reduced number of neutrophils. Lymphopenia is less common. In addition to congenital immunodeficiency disorders, it is most commonly seen in HIV following therapy with glucocorticoids or cytotoxic drugs, autoimmune disorders, malnutrition, and certain viral diseases. Neutropenia, agranulocytosis. Neutropenia is reduction in the number of neutrophils in the blood. It can be caused by inadequate or ineffective granulopoiesis. It is observed in the setting of suppression of hematopoietic stem cells, suppression of committed granulocytic precursors, rare congenital disorders, increased destruction of sequestration of neutrophils in the periphery. Accelerated destruction of secretion neutrophils occurs with immunologically mediated injury to neutrophils, splenomegaly, increased peripheral utilization of neutrophils, overwhelming bacterial, fungal, and rickettsial infections. Agranulocytosis is the condition in which the absolute neutrophil count is less than 100 neutrophils per microliter of blood. It may be acquired or inherited. It is a serious condition and can be a life-threatening one. Prompt diagnosis and treatment are needed to avoid mortality due to septicemia. The most common cause of agranulocytosis is drug toxicity. Certain drugs, such as alkylating agents, and antimetabolites used in cancer treatment produce agranulocytosis. The symptoms and signs of neutropenia are related to infection and include malaise, chills, fever, followed by marked weakness and fatigability. With agranulocytosis, infections are often overwhelming and may cause death within hours to days. Leukocytosis, it refers to an increase in the number of white cells in the blood. Mechanisms and causes of leukocytosis: increased marrow production, increased release from marrow stores, decreased margination, decreased extravasation into tissues. Increased marrow production, chronic infection or inflammation, growth factor dependent, paraneoplastic, example Hodgkin lymphoma, growth factor dependent, myelodependent neoplasms, example chronic myeloid leukemia. Increased release from marrow stores, acute inflammation, chronic inflammation. Decreased margination, exercise, catecholamines. Decreased extravasation into tissues, glucocorticoid. Neutrophilic leukocytosis, acute bacterial infections, especially those caused by pathogenic organisms. Sterile inflammation caused by, for example, tissue necrosis. myocardial infarction, and burns. Eosinophilic leukocytosis. Eosinophilia causes are allergic disorders such as asthma, fever, hay fever, parasitic infections, drug reactions, certain malignancies like Hodgkin and non-Hodgkin lymphomas, autoimmune disorders like pemphigus, dermatitis, herpetiformis, and some vasculitis. Monocytosis causes are a chronic infection, example tuberculosis, bacterial endocarditis, malaria, autoimmune disorders such as SLE, inflammatory bowel disease, like ulcerative colitis. Lymphocytosis accompanies monocytosis in many disorders associated with chronic immunological stimulations, viral infection, and bone particular infection. A few other things to note are hypersegmentation, presence of Dole bodies, and toxic entities. Lymphadenitis. Lymph nodes undergo reactive changes in response to a wide variety of stimuli, which include microinfections, drugs, environmental pollutants, tissues, and tissue injury. Immune complexes are malignant nucleus and malignant nucleus. However, the most common cause of lymph node enlargement are inflammatory and immune reactions aside from primary malignant mechanisms and metastatic tumor deposits. Those due to primary inflammatory reaction are termed reactive lymphadenitis, and those due to primary reactions are termed virus lymphadenopathy. Acute reactive lymphadenitis. All kinds of acute inflammations may cause acute non-specific lymphadenitis in the nodes draining the area of inflamed tissue. Most common cause of microbiological infections or the breakdown products and foreign bodies in the wound, foreign circulation, etc. Most frequently involved lymph nodes are cervical due to infections in the oral cavity, maxillary due to infection in the arm, inguinal due to infection in the lower extremities, and mesenteric due to acute appendicitis. Morphological features की बात की जाए, grossly the nodes are swollen, braided and engorged. Microscopically, the prominence of large epithelial centers containing numerous mitotic figures. Macrophages often contain particulate debris derived from dead bacteria or necrotic cells. When pathogenic organisms are the cause, neutrophils are prominent. At the centers of the follicles may undergo necrosis. Sometimes the entire node is converted to pus with less severe reaction described in neutrophil infiltrate. About the follicles are equated with the lymphocytosis. The endothelial cells lining the sinuses become activated in large cells. Chronic reactive lymphadenitis. Chronic non-specific lymphadenitis, commonly called reactive lymphoid hyperplasia. It is a common form of inflammatory reaction of draining lymph nodes as a response to antigenic stimuli such as repeated attacks of active lymphadenitis tumors. Depending upon the pattern in chronic non-specific lymphadenitis, three types are distinguished, each of having its own set of causes. These are follicular hyperplasia, pericordial hyperplasia, and sinus cysticercosis. Follicular hyperplasia is the most common frequent pattern, particularly encountered in the children. Microscopically, in follicular hyperplasia, there is marked enlargement and prominence of the germinal centers of lymphoid follicles, proliferation of B cell areas, due to the presence of numerous mitotically active lymphocytes and proliferation of phagocytic cells containing phagocytosed material. Parafollicular and medullary regions are more cellular and contain plasma cells, histiocytes, and some neutrophils as well as eosinophils. There is hyperplasia of mononuclear phagocytic cells lining the lymphatic sinuses in the lymph. Pericortical lymphoid hyperplasia in it due to hyperplasia of T cell dependent area of the lymph. Amongst the important causes are immunologic reactions caused by drugs, for example, talented vaccination, viruses, example, infectious mononucleosis, and autoimmune disorders. Microscopically, expansion of the paracortex T cell area with increased number of T cell transformed immunoblasts, encroachment by the enlarged paracortex on the lymphoid follicles, sometimes resulting in their replacement, hyperplasia of the mononuclear phagocytic cells in the lymphatic sinuses. Venous histiocytosis, very common type found in regional lymph nodes, draining inflammatory cells, or as an immune reaction of the host to a draining malignant tumor of its parents. The hallmark of histologic diagnosis is the expansion of the sinuses by proliferating large histiocytes containing phagocytosed material. The next one is leukomet reaction. Leukometation is defined as a reactive excessive leukocytosis in the peripheral blood resembling that of leukemia in a subject who does not have leukemia. And the characteristic features of leukemia like splenomegaly, hepatomegaly, lymphadenopathy, and hemorrhagia. Causes are there are several causes for leukomet reaction. Example, number one, infections. Example is staphylococcal pneumonia, disseminated tuberculosis, meningitis, diphtheria, sepsis, endocarditis, plague, infected abortions, etc. causes excessive increase in the leukocytes. This leukomet reaction. Intoxication, example, eclampsia, mercury poisoning, severe burns. Malignant diseases, for example, multiple myeloma, myelofibrosis, Hodgkin's disease, and bone metastasis, and severe hemorrhage and severe diseases. When we talk about the blood picture seen in the leukomet reaction, there is usually leukocytosis usually moderate but not exceeding 1 lakh per microgram. Proportion of immature cells is mild to moderate, comprised by metamyelocytes and myelocytes, and blasts greater than 5%. That is the blood picture simulates somewhat with that of the CML, but there is underlying cause is present in leukomet reaction. Infective cases measure toxic regulation in Dole bodies in the cellular neutrophils. Neutrophil or leukocyte alkaline phosphatase score in the cytoplasm of mature neutrophils in leukomet reaction is characteristically high and is very useful to distinguish it from chronic cases. Now we are speaking about sarcopenia vera. It is a clonal disorder characterized by increased production of all myeloid elements resulting in pancytosis, that is increased red cell, reticulocytes, platelets in the absence of any recognizable cause. The term polycythemia vera or polycythemia vera is used for primary leukocytic polycythemia and most common of all myeloproliferative disorders. Secondary polycythemia or erythrocytosis of the other end may occur secondary to the several causes, example, high altitude cardiovascular diseases, pulmonary disease and tubular hyperventilation, heavy smoking and electromagnetism burning like in the case of cancer carcinoma, hydronephrosis, or hypertrophic carcinoma, cerebral meningioma. Clinical features are headache, vertigo, tinnitus, visual alterations, syncope, and even common. increased risk of thrombosis due to accelerated atherosclerosis, increased risk of hemorrhages due to increased blood volume and intrinsic platelet dysfunction, example epistaxis, lactic ulcer disease, splenomegaly producing abdominal illness, pruritus, especially after bath, characteristic. The lab findings in the polycythemia vera raised hemoglobin concentration. The criteria is above 70.5, 14.5 gram per deciliter males, 15.5 gram per deciliter females. Increase in the hematocrit above 55% in males and above 47% in females. Mild to moderate leukocytosis with basophilia and raised neutrophil as well as phosphatase post thrombocytosis with defective platelet function. Apart from that, pulmonary examination revealed hyperplasia, and hyperplasia. Cytogenic abnormalities such as 20q, trisomy 8, and 9p are found in 30% of